Thank you. Hi, everyone. Georg Schmoelzer from Edmonton, Canada. And thanks for all these great presentations before. And I will just add to this one with basically the last area of the NLP part, which is test compression and epinephrine. And I will do two things. I will have all the guidelines in, but also all the studies recently published. There's a lot of things coming out lately about chest compression. I remember that I forgot to add the disclosure slide. So the only thing I really would like to disclose is some funding to perform some of these studies as well. And I'm also a member of ILCOR, the International Liaison Committee on Resuscitation, produces those guidelines. Now, I don't need to talk much about this because Dr. Rehab already spoke to this. But in the end, even though we're trying a great job, there's still a lot of newborn babies who don't make it, and certainly we can improve, in particular when we're providing chest compression and or epinephrine. Now, whenever you do either of them, you have a high rate of mortality as well as morbidities, and certainly if you do provide chest compression for a longer period of time, the outcomes are rather bleak. Now, we know we have poor prognosis associated with receiving chest compression, with or without medication. And it always raises the question if there is specific techniques you could use in the delivery room, so basically tailored to the newborn infant. And what's the problem? Well, the problem is that we never know when we're going to have to do CPR. So it's quite infrequently used. Like in our unit, we have around 7,000 high-risk deliveries. We have maybe 20 babies a year, so it's not really often happening. So it's really challenging for us to do any research in this area. Now, if you look at the NLP textbook or the guidelines, these are the recommendations for chest compression, and most of them are basically from animal data, from human data, mainly adults or pediatrics, so the data in newborns is rather limited. So what do they say? As we already heard, if the heart rate remains less than 60, you did your Mr. Sober, you might have intubated or put a laryngeal mask in, and you provide positive pressure ventilation, and you still don't get an increase in heart rate, you need to start chest compression. I tell you, use 3-to-1 chest compression to ventilation ratio, so you use 90 compressions and 30 inflations. And you do 1 and 2 and 3 chest compressions, then you stop for 1 inflation, and then you do that again. You want to do the chest compression as fast so that you get roughly 120 compressions per minute. You should use the 2-thumb encircling technique, and I will have a photo later about that, over the 2-finger technique. And you can perform it from the side, which was the one always recommended, and in the last 3 years, NLP recommended that you can also come from the head. And you should basically squeeze the chest 1/3 of the anterior posterior diameter of the chest, and use 100% oxygen. Now, there was a couple of studies recently published, and just recently, like in the last 2 years or so, if there's any evidence that we should start when the heart rate is less than 60, or is this too early? And the study is basically out of lambs, one a few years ago, one more recently. And what they showed is that they're not 100% sure if this is the right thing to do. Certainly what they found is when you start chest compression and there is still a heart rate, you interrupt the blood flow, and you might interfere with carotid blood flow to the brain. So it maybe is not the best, but that's the current recommendation. So we will still continue to start chest compression as long as the heart rate is less than 60, but still watch that space. Maybe in the next 3 years, those recommendations might change. Now, there was quite a nice review now, quite like 6-7 years ago now, by Solowak and all, who looked at all the factors which could influence the efficacy of chest compression. And I will go now through most of them, because there is a lot of new data coming out in the last little while, which affect some of these factors. Now let's start with chest compression then. I told you 1/3 of the anterior posterior diameter. Now, what's our problem? But if you work in adults and pediatrics, you get feedback mechanism. You know, with the defibrillator or with little cards you can put on the chest, how deep you're pushing. We have no idea because we have no feedback mechanism. Where is the evidence from? Well, the evidence we have is quite limited. And what we know is that there's two studies. One used CT, one used MRIs, and they looked at, okay, how deep should you squeeze the chest that you get cardiac output? And what they came up with in the model was at 33%, so 1/3. Because if you do 50%, you might get more injury, and if you do only 25%, you don't get enough cardiac output. So, as I said, our main problem remains that we don't know how deep we should press because we don't have any feedback mechanism. We don't want to overpress and we don't want to underpress. Now, a study by Prof used a machine in a piglet model, as a newborn piglets, to see, okay, squeeze the chest in certain posterior diameters, and they did 12.5%, 25, 33, 40%. And as you can see, they measured the time to ROSC, so that's the time to return of spontaneous circulation. And if you did 12.5%, 12.5 is certainly not enough. But with 25, 33, and 40, the times were roughly the same. 33 was the best. But the hemodynamic parameters seem to be better with 40%. So in the end, they were saying that maybe, you just need a threshold or somewhere around 33 to 40%. So maybe the best to squeeze hard and fast to get the best result. Now, what's the rate we're using? Now, the rate we're using is 90 compressions, which should be done in the speed of 120 compressions per minute because you're stopping for the breathing in between. Now, just remember the normal heart rate in the newborn is 120 to 160, so slightly higher than what we're actually compressing. So the optimal chest compression rate is rather unclear. And if you go back a few decades or so, there's a team from Philadelphia who created a mathematical model. And they said, if you're a German baby on 3 kilos, you should have a chest compression rate of 180. Basically impossible for us to do. And certainly, if you look at simulation studies, even if you just go up by 30 chest compressions a minute, you get a much faster fatigue. Same team, Prof, they used the machine again. Compared different, chest compression rate. They started at 60, 90, 120, 150, 180, and found that the faster you go, the higher the stroke volume is getting. The stroke volume goes up to around 150, and then it plateaus off, but the cardiac output becomes higher. It's just a formula of stroke volume times rate. Left ventricular function might be optimal with 150. Nonetheless, of these findings, they used and compared 90, 180. We found that even though 180 was faster, significantly in the study, just used the sample size of 8 and more. Now, I'm not saying that we need to start squeezing harder or faster, but certainly I think it gives us maybe a little bit of leeway that if you're not doing it exactly at 90 per minute and you're slightly faster, it might be not bad for the baby. It might be good for the baby. So I think it might help also to reduce some of the stress that you don't have to watch it that closely that they're right at that rate. Now, what's with the correct technique? And then the correct technique is quite interesting because over the last 3 years, there's so many different hand or finger position techniques emerging that it's really hard to keep track. Now, this is what the NLP tells us. And if you look at A in the left corner, this is the Q-sum technique. C, the next to it, is the one over the head. And B would be your 2-finger technique. And then there is like at least 7 other or 5 other techniques available, and they're all summarized in this review, which have been studied in mannequins. And most of them are quite successful, like they are comparable to the 2 fingers or comparable to the Q-sum. Now, the team by Bruckner again tried to see if they could compare those in a pilot model again, and what they found is that the two-sum is certainly, or if you do it from the side or from above the head, it's better from a stroke volume, so you get better cardiac output, and you get better left ventricular function. So I think regardless of whatever else technique is out, at the moment, it would be the two-sum technique we should be using. And this is just the summary of their results, where they found that providing blood flow as well as the expression of left ventricular function was improved. So keep the two-sum technique. Now, I think one of the biggest areas is balancing your compression to ventilation ratio and what is the best compression to ventilation ratio. Because if you go back in history and you read the resuscitation of the newborn, they used the 1 to 5 compression to ventilation ratio, so 5 chest compression, 1 ventilation, and then NRP came along, and just out of the blue said, let's do 3 to 1. So there's no evidence behind to use that. That's what the guidelines tell us. Now, these are the rationales. If you read the guidelines, this is exactly what they say, that they have a higher physiological heart rate, higher breathing rate, bradycardia due to cardiac arrest due to hypoxia, so we need to work more on getting air into the system. Now, there's many studies out who tried many different things in neonatal resuscitation, and they were all in piglet or sheep models. Now, they tried 2 to 1, 3 to 1, 4 to 1, didn't make any difference in how long they were resuscitating or any other outcome. They tried to do what the pediatric world does, 15 to 2. They tried 9 to 3, just tripling what the 3 to 1 is, and again, didn't find any difference in the time they were doing chest compression or mortality. Now, in the pediatric world, they would use continuous chest compression and just do non-synchronized or asynchronized ventilation after the breathing tube goes in. And that also was tried in 2 different models in the neuro world. One was by myself, and both of these studies found that it doesn't really make a difference if you use this approach. It will not improve your time to return of spontaneous circulation or your mortality. Now, I need to disclose that this is something we do or we have studied over the last 10 years, and it's still a research project, so please don't go home after this conference and start doing this in your delivery room. But we used a different approach, and we made a mistake. We called it sustained inflation, because when we started doing this 10 years ago, it was, everybody was jumping around and was happy doing sustained inflation. So basically what we did was using a high distending pressure like CPAP, just high at 25 centimeters of water, and provide a chest compression on top of it. And then if you read the guidelines, you will see this as an alternative technique, which should only be used during research. And why is that something which is in the guidelines, and the guidelines are interested that there is more studies to be done. Now, when we compared this technique, and I have a video about the technique in a minute, you can see that it was basically 75% faster to get the heart beating again, and the survival was much, much higher. Now, if you look at your 3 to 1, this is how 3 to 1 work, and 1 and 2 and 3 you breathe, 1 and 2 and 3 you breathe, 1 and 2 and 3 you breathe. So your classic, what you have done was likely many of you several times. With the other technique, you just close the T-piece, like it would provide sustained inflation or high distending pressure, and you give continuous chest compression. Yeah, so there's no counting, you're just doing compression. We decided to do that for 20 seconds, and then you just lift off your finger from the T-piece for 1 second, and then close it again and continue. So relatively easy. Now, what's the difference between the two methods? I think one of the differences is that when you look at here, you can see that the pressure, this is your inflation, and then you do 1 and 2 and 3, breathe, and 1 and 2 and 3. So you get pressure, basically inflation in, and then you squeeze 3 times the chest, and you will lose some volume every time you squeeze the chest. And this is the difference with this technique. So now when you do this other technique, you can see that the air goes in, and because you squeeze the chest, the air comes out. But when you release the chest, air goes in because you use that high distending pressure. So basically, you ventilate your lung every time you do chest compression passively. What's the benefit? We have this problem when we do chest compression. The pediatric world has a problem. The adults have the same problem. When you do chest compression, every time you squeeze the chest, you get air out of the chest, so you lose your FRC. That's a big problem. And that's certainly what happens when you do 3 to 1. But with this other technique and the adult world, there are studies with that same technique as well as in the pediatric world. It helps to keep your lung aerated and your lung keeps your FRC. That's certainly an advantage. Similar, doing continuous chest compression, that's why the adult and the pediatric world does that as well, is that you get an increase in your hemodynamics. So certainly something worthwhile to further investigate. So these are those two mechanisms I was just briefly describing, that you get improved lung aeration and improved hemodynamics. Now there's several other studies from other groups who also showed that this technique is feasible, and after quite some studies in animals, we have started to work on small trials, because you have that small to get bigger. And as you can see, this was the first pilot trial several years ago now in preterm babies, and it showed basically the same, around 75% faster that the heart was beating again. So certainly quite nice. So we started a bigger trial, which was done in several centers, and we tried to find out if this helps to decrease the time to ROSC. So we were quite ambitious and said, let's try 218 infants to see if we can reduce the time we're doing chest compression by 33%. Include all kids or newborns, preterm or term, and you would be randomized as a hospital to 12 months of one or the other technique. These were some of our outcomes we recorded. Yeah, we started, we got a lot of media attention because we invited the media to join us to advertise for the trial, and then everybody traditionally went same, where the initial sustained inflation at birth was increasing mortality, so everybody was scared, so we stopped the trial. We had to change a few things to be able to continue, and over a period of 5 years with many issues, we were only able to include 11 kids in this new technique and 14 in with 3 to 1. It shows you how challenging it is to get a chest compression study done. It took us 5 years to get those few patients. Now it's really hard. That's why we often don't have evidence to what to do when we do chest compression. Now, there was no difference in all the interventions we did in the delivery room, but if you look at the time, the chest compression, even in the small sample size, you can see it was 90 seconds of chest compression with this new technique, and 615 seconds, almost more than 10 minutes with the 3 to 1. So even that small sample size, this was significantly reduced, which we were quite surprised that we already saw this with this small sample size. So we always have to take it with a grain of salt. And also the survival was slightly improved. The number is so small, so it's not significant, but they are certainly not too much different than what is published in registries. Secondary outcomes we were looking at, including HAE, there was no difference. So now, it's promising, there's a signal, but certainly not something you should start going away and doing in a delivery room. However, what we're going to do is, because now we have 2 studies, we will try to do another study, hopefully this time with more success. So stay tuned, maybe in a few years, this might be something you will all do, because it is maybe showing that it is better. Now, the last 2 points I wanted briefly to touch base is oxygen concentration, because you have to start oxygen with 100%. When you start chest compression, that's the latest time you should start 100% oxygen. But what's the evidence for it? Well, there's 7 randomized triplet studies, and that's all we have, which compares 21 versus 100%. So the evidence is not really much, and there's often the question, take 21% versus 100%, it didn't show any difference, but would you use 21%? if you ask a lot of clinicians and if you try to organize a clinical trial, a lot of physicians would say, no, I don't want 21%. I'm maybe happy with 50, maybe 60, or I would go as I would start at 80 maybe, but certainly no one would do 21. So certainly, that might be interesting. Maybe there's a middle saturation or concentration we can use, but there's certainly a lot of work to be done to see if we ever find the optimal oxygen concentration during CPR. The last point is epinephrine, because that's the only drug we have for CPR in our newborn babies. And the guidelines tell us to use a dose between 0.1 to 0.3 milligrams per kilo. And NFB was quite smart. They said, look, that's way too complicated. Use 0.02. So they just simplified it so that you just have one dose in your mind to calculate. It's your IV dose, and you can repeat that every 3 minutes, 3 to 5 minutes. What's new in the latest edition is that you should, instead of having just a half a milliliter or 1 milliliter flush, use a 3 milliliter flush, because then you can really flush it in. And in a cheap study that's shown that improves the chance of ROSC. Now, all these data are based on animal data because there's no human neonatal data. And if you look at what INCO did a few years ago, you can see that there's a few cohort studies, but that's about it in human data what's out there. So it's really, really limited of what we know if epinephrine is the right drug and the right dose we're using at the moment. It's really hard to use animal studies because almost all animals need epinephrine to get the good spontaneous circulation. So it's really, really challenging to know, oh, okay, this is good evidence because they need it, otherwise they don't come back. Now, several studies have compared how you should give epinephrine. Now, ILCO says give it IV and only give endotracheal if you don't have an access yet, like a umbilical venous catheter, because it's not as effective. And quite interesting, if you look at different animal studies, if you look at an animal study where they have a lamb which has fluid-filled lungs, and then you use a lamb where it was aerated, so the lungs are aerated, like let's say a day later, epinephrine works well in those aerated lungs when it's a day old or 2 old, but it doesn't work at all at birth because it seems that when there's a lot of fluid-filled lungs, the lungs are fluid-filled, and you give epinephrine via that endotracheal tube, it just dilutes and doesn't get absorbed. So it's still recommended, but it might not work. So don't expect it to work. Yeah. And the moment you get your umbilical catheter, give another dose. Don't wait those 3 minutes. Give another dose so that you make sure that you get epinephrine in the system. And what's brand new, like in the latest edition, is that they also, the latest guidelines, they recommend intraosseous. Because a lot of people struggle to do umbilical catheters, and you're often alone, like if you're alone with one nurse, for example, it's really challenging to chest compression ventilate and do the line. So if you get a drill or you get the screw in and give the epinephrine that way. Same dose with the same flush. And animal studies have shown it is as successful to get the epinephrine where you want. That's certainly an alternative. And there's not many reported side effects. There's every now and then, yes, you might get a necrosis or you get an infection, but that's from the stuff which is reported in humans, it's relatively rare. So not something we need to be too afraid, but certainly practice might be on chicken bone or turkey bone people use in simulation settings might be something worth trying just in case. Good. So remember, these are guidelines which is the chest compression approach we should use whenever we have a kid who needs chest compression. That's all I got. Thank you.